Good evening, my friends, my colleagues. Today we'll have, I think it will be a wonderful webinar, as usual, from our two international speakers and national and international speakers, my friends. This is the CVREP Acute Mi, and we'll go for 1.5 hours for this webinar. Regarding the first talk, I was concerned 1 month ago to present this talk about the acute myocardial infarction, or the management of acute myocardial infarction in the COVID era. So I'm spread it to the management of acute infarction, STEMI and non-STEMI, in the COVID era. The second talk will be by Professor Hussam Andil, Professor of Cardiology, Cairo University. He's going to speak about the new era of dyslipidemia management through PCSK9, through prevention, also cardiovascular events. And we'll have discussion after the first talk, also the second talk. The third talk by my colleague and my friend, the young professors, but is rising stars, Professor Ahmed Shawi. Actually, Ahmed is a wonderful presentation, and we'll make it in a case. This is the real myocardial infarction case or acute coronary syndrome presentation, and Ahmed will have questions, and please vote for this question during the presentation, and then we'll have discussion, me and Dr. Hussam with Ahmed, and the same with my talk and Dr. Hussam too. This webinar is accredited by the American Associations of Continuous Medical Education, AACME. It's very important to be accredited this webinar. And this is organized by the CVREP, which is as you know, cardiovascular research, education, prevention, and is powered by the company which Amgen. And thanks to Karen who helped me and Hussam and Ahmed for the medical part of this webinar, and also thanks to the organizers, which is ICOM company, Riham, and her group in preparation of the talks and the connections, and then technical part by Boulos, Ahmed Yosfi Boulos, and his colleagues, the Media Factory by ICOM. So I will start the first presentation, if you allow me, to this first presentation. The COVID-19 cardiovascular, as you can see, the background of the slide is the COVID, so the spikes is the circular part with the spikes. And this COVID virus stayed with us, is still staying with us, but actually it's decreasing. It starts in Egypt in the beginning of March. And then we have a lot of information about what are the high-risk populations. What the mean HRP, which high-risk populations, because these patients are the patients who are more vulnerable at that time for the COVID, so high risk for severe illness. Those are the elderly, the people 65 years and older, those who are living in a nursing home or long-term care facility, those with the underlying medical condition, particularly if not well tolerated, chronic lung disease, asthma, serious heart conditions, immune compromised, obese, diabetics, chronic kidney disease, and liver disease. So this slide is very important to see what about the serious elements with patients who died with this high-risk population, starting from no existing condition, 0.9, to cardiovascular disease is 10.5. Diabetic patients, 7.3. Strange enough, the chronic respiratory is 6.3, which is less than the cardiovascular disease and diabetes. And then the abnormal high blood pressure alone is a risk factor, and cancer is less already, although this immune compromise. You can see the difference in the high-risk population and the cause of death. Then come cardiovascular manifestations. We have a lot of lab. One of these important lab, this is a review articles on JAMA in March 27, 20, potential effect coronavirus on cardiovascular system. We can see that this viral infection had a lot of mechanisms in order to have these complications. It's a direct vascular infection, increased vascular inflammations, leading to myocardial infarction risk increase. Systemic inflammatory called cytokine storms, which are with the interleukin 6 and tumor necrosis factor, and interleukin 1. hypercoagulability leading to plaque rupture. This will lead to also increased myocardial infarction risk. There's increase of sympathetic stimulation, leading to increased myocardial oxygen demand, and finally leads increased myocardial infarction. So there is a lot of infarction, myocardial infarction, due to the sympathetic hypercoagulability, cytokine storm, and direct vascular infection. Then come to acute respiratory distress. These following cytokine storms: in hypoxemia, leading myocardial oxygen supply is decreased, leading either to increase myocardial infarction risk or to increase heart failure risk if you are already in heart failure. Increased sympathetic stimulations, leading to increased demand. Myocarditis, myocyte necrosis. It was found that a lot of myocarditis in SARS, but at least in COVID cases, reported cases about myocarditis. Increased pro-inflammatory cytokines, leading to myocardial depression, direct myocardial infection, myocarditis. All of this lead to increased heart failure risk. Finally, the arrhythmia risk due to stimulation, sympathetic stimulation, increased pro-inflammatory effects, myocardial. As we can see from this slide, there are a lot of mechanisms. That's why the cardiovascular disease at the high risk of death. Both SARS and MERS, acute myocarditis, myocardial infarction, rapid onset of heart failure. Regarding the COVID-19, 4 out of 5, there's increase of troponin, but 4 out of 5 admit to ICU, there's serious nature of myocardial injury, so increased troponin. Among the confirmed COVIDs, among these COVID mortality cases, 11.8% without underlying cardiovascular disease have substantial heart damage that say there is elevated troponin or cardiac arrest during. So that's why cardiac troponin is very important in diagnosis that the patient is going to have a serious disease. Then the JACC, on the American College of Cardiology's publication, a position statement that in cases of COVID, there is acute cardiac complication, 16.7% arrhythmia, 7.2% experienced acute cardiac injury, and acute onset of heart failure, myocardial infarctions, myocarditis, and cardiac arrest. This, if you sum up the exact pathophysiology of myocardial injury leading to increased troponin, direct damage by the virus, systemic inflammatory response, destabilize coronary plaque if you have a plaque, and aggravated hypoxemia. These 4 mechanisms leading to experienced myocardial injury after infections and higher risk of death. It is speculated by 2 studies, that's by Wagin et al. And then China, from JAMA 2020, Marsh and Marshall also, that this cardiac injury elevated troponin is 7.2% and 12%. Then they divided the myocardial injury into 3 types. Either myocardial injury was due to cytokine storm. In this patient is early after symptom onset, say this fever, the symptom of COVID, this increased troponin following other biomarker, and the patient have only type 1 myocardial injury. Type 2 myocardial injury or viral myocarditis or stress cardiomyopathy. This is called Takotsubo-like syndrome. These cardiac symptoms are chest pain, ST segment elevation, depressed ejection fraction, but normal coronary angiogram. So we have Takotsubo with normal coronary angiogram. Myocardial injury only lab with symptoms after the starting COVID. Then type 3, which is acute coronary syndrome, which is plaque rupture with destabilization of the plaque and then demand ischemia. As you can see here, the troponin outcome with the COVID-19 in this slide, that the days of illness is increased. This is the red is non-survivors, and the blue is the survivor with high sensitivity troponin. With increasing of troponin along the days from illness onset, there is increase of non-survivors here if you have up to 22 days from the onset of onset, with the increase of high onset of troponin. Regarding D-dimer, also the same curve, the interleukin-6, the same curve, this high sensitivity troponin, and LDH, and also the serum ferritin. But however, in case of lymphopenia, with decreasing of lymphocyte, there is increased number of non-survivors rather than the survivor, which is the blue one. So these are the biochemical factors which you can see and influence the severity of heart disease and the cause of death. This is a review article also from JAMA about the cardiovascular implication of fatal outcomes with coronary virus disease. regarding the same for the troponin and the with or without cardiovascular disease. Without cardiovascular disease, a normal troponin in the patient with COVID, mortality is only 7.6%. If you have a cardiovascular disease with normal troponin, 13.3. If you have without cardiovascular but elevated troponin alone, mortality 37.5. If you have both, the mortality increased to 70%. The same for if you compare the patient with troponin and patient with propionation, hospitalization, and pending death, where for the fatal patient and the cure patient, as you can see, the plasma troponin increase in patient with the impending death. The same for propionP in the fatal patient. With the cure, if you have a cure, the results will be the same here or decreasing for approaching discharge. The Birmingham and the women's hospitals in London, you can see that there's a consultation cardio. I'm not going into detail, but you should have in your hospital cardiology consultations, and this is the expert consensus, the principles, clinical management of patients, running trials. If you have a confirmed or suspected cases, so isolations in designated, it's called designated hospital, COVID-19. Then single room suspected case, the medical treatment for this patient. If you have an invasive criteria, there you have a go for emergent invasive, even in designated hospitals. If there is no evidence of non-emergent invasive, no also for elective invasive intervention. But in non-designated hospital, just speaking with Dr. Ahmed Shabat, designated, non-designated hospital, you can do lung CT scan and nucleic acid in the patient coming with chest pain without ST elevation. Confirmed suspected case, if yes, go designated hospital. If no, routine treatment in non-designated hospitals. This is at the beginning. Then the cardiac biomarkers, you have to measure it. You have make a telemetry, ECG, transthoracic echo, and called focused transthoracic echo, stop advanced imaging, and then work up with this patient. Then comes to the guidelines. We have a history of guidelines. Started just speaking with Dr. Shai about the guidelines started by SKY. And this I'm going to start with you during the starting of the pandemic. What happened in the pandemic, SKY? According to this, divide the patient into a patient confirmed COVID-19 or person under investigation, PUI. This PUI, fever, respiratory symptoms, foreign travel within 14 days in the level 2 to 4 travels. So the guiding principle at that time, all STEMI should be brought to the cardiac cath laboratory for primary PCR. Systemic fibrinolysis will be considered for low risk. But what is low risk? Inferior myocardial infarction without right ventricular movement. This is done in their hospital because the rush of the patient in the COVID and non-COVID hospitals. The bedside procedure of the say intra-aortic balloon pacemaker precaution, this is ECMO, should be done outside the cath lab. For maximum protection in all the patient PPE, do only the culprit vessels. Performing intracatheter intubation in the CCU should be avoided. A single procedure room, I mean, you should have a COVID, which is not available in our country, COVID room, to have 2 cath labs. And also we don't have this what's called negative pressure, airflow modified negative pressure. And also we don't have utilization HEPA filter in the room. This is the rules of the SKY at that time. And this is same for the risk STEMI and also for non-STEMI, do for very high risk patients only. Then the European Society go the same, STEMI, non-STEMI. Finally, what started and this is also in June accepted 2020, and starting from June till now, we are making with the European and American College about the management AMI with this track. EMS field of STEMI, which is COVID unknown, the yellow here, go to the emergency department, then do screening, pulse oximetry, then a focus echo, consider COVID-19 myocarditis, ultra-rapid testing, if available. If you're not available, don't depend on this. So if this STEMI and COVID-19 positive or probable, with attendings, loaded go to the cath lab, which is dedicated, and in these patients, and also in other patients non-COVID, PPE for a rise and droplet precaution, very important, and then arrange for ICU isolation if you are suspecting COVID. If you have a STEMI and possible COVID, standard STEMI curve in the non-COVID cath lab, also universal use of PPE for a rise droplet infection. Regarding the STEMI at referral hospitals, not in the possible hospitals or available cath lab in the hospitals. STEMI, the referral hospital should discussion with the transfer hospitals. If you have a long day, like any guidelines, it's delayed, so you do pre-transfer primary lysis. But if not, depending on COVID-19 possible, the same primary PCI or primary PCI fibrinolysis if it is long. Primary PCI and primary fibrinolysis then PCI. This is in these patients. But in the receiving hospitals, in the COVID-19 rescreening opportunity, it's called ultra-rapid testing. I think it should be within the next few months. It should be available in our hospitals. Ultra-rapid COVID-19 testing, if available. STEMI COVID-19 positive or STEMI COVID possible, consider myocarditis in all of these patients and consider STEMI diagnosis. This is by the echo, and then the same for the vessel PPE. But the difference in that if you have a COVID-19 positive, probably you should arrange isolation ICU. Here, it's not recommended to arrange for ICU isolation. So if there's still elevations for the COVID-19 positive, for the ultra-rapid here on that, symptom consistent MRI, yes. Consider POCUS, point of care ultrasound. Very important. What's the meaning of POCUS? That you should only go to with one point to do the echo, not doing the echo the whole around, take long time. It's called POCUS, point of care ultrasound, to confirm wall motion. If STEMI, go for prime PCI. Here in the symptom, see with the MRI in the possible COVID, and then ECG consistent MRI, STEMI. If the POCUS is unclear with the echo, do serial ECG, portable X-ray, and consider myocarditis for this patient, and you have to take a decision regarding this is the time and this kind of patient intermediate do regarding coronary CT angiogram or cardiac, which usually take minutes in order to reach the diagnosis and do primary PCI for them. So the guidelines, what has changed in 2020 and what the European recommendation, it is the same. It is the four colors in the European between elective, green, yellow, low priority, orange, urgent, emergency, red. In general, CTO should be elective, but even with angina class 2. In emergency, STEMI with non-STEMI, the very high risk and cardiogenic shock. In urgent, in all kinds of non-ST, and in the last remaining vessel and cabin patient non-ST. In lower priority for this patient, advanced angina, stage PCI, non-culprit. This is a low priority if you do culprit to the primary PCI. For the non-culprit, it's low priority, can do delayed up to 3 months. Proximal LED lesion should be here. So this is called, you should take care of, this is the European side, the same for the European. The European also, for the STEMI, transport to hospitals. Transport to hospital, even at hospital without 24, transfer to a timely primary PCI. If it's prolonged, primary loss. If it's short, go to the primary 24 cath lab service. So what's next? Next, this is the last month about in May, 4, 2020, continues with the American self-reintroduction of the service. I think this comes from all these societies, the American College or the CAI for the Society of Thoracic Surgeons, so on, a lot. This is 16 societies rendering this. This is ending in this table, what's called safe reintroduction of invasive procedures during the COVID era, because we are continuing with the COVIDs. We are not finished the COVIDs. You have to have 3 levels, level 0, level 1, level 2. Level 0, that's regular services, let's say ongoing COVID testing and surveillance. Level 1 is reintroduction of most services. Level 2 is reintroduction of some services. As we can see, routine service of all cases for acute coronary syndrome. STEMI, you can do all cases here. All cases for me, whatever the levels. But the ACS here, divided in those high-risk patients here, and medium low, they can show category for low-risk medical, medium selective, and then in the reintroduction of most service, you can see in low-risk here, unstable selective invasive, but this is medical. Here, invasive, and this is select. So in level 1, more action. Level 0 is can do all services. This is, should be put in any hospitals according to the circumstances of the country, the town, the hospital itself, and even in TAVR, even in elective cath lab, in mitral clip, in if you are looking to this, you can look to the to my slides here, and you can also go for a Jack or to the ECC to see what's going with the introduction of invasive procedures. And finally, my colleagues, the solution of the COVID pandemic, depending on the clinical and scientific flexibility. And thank you very much. And waiting for the cardio, Alex. Actually, is not canceled, but it's only postponed to 5 to 9 of October 2020. So we are not canceling, we are only postponing. I hope we can finish the program as soon as possible, and we can go either physically or on hybrid one. Thank you very much. Any question from Dr. Hussam, Dr. Ahmed, and
of course, a very nice presentation. I think each country will have its own different circumstances. I think in this era, I think we are witnessing a major change in our practice, at least for myself. I'm not sure about Ahmed. Maybe you will also feel that this 3 or 4 months of disturbance in work, patients are not having the same financial power. Hospitals are suffering, not only in Egypt, but all over the world. We know that in the United States as well, they are having big trouble paying for the services that their patients have. So I think we are in an era where we have to adapt to these changes, do the minimum that would let the patient get safely out of the hospital, and at the same time maintain the safety of our staff, our physicians. So I think you have done a great job. I think you have reviewed all possible scenarios, and I think in our country we have the discussion that you had with Ahmed before we go on air. It was clear that each hospital has its own regulations, and I think the more simple regulations for me will be the better. I use thrombolytic therapy in the patients that I can use thrombolytic therapy as in guidelines. Low-risk patients, they definitely can escape going to the cath lab. I do only the very necessary interventions, and many of my interventions are postponed until the patients are ready to do that, because I don't want to put any further financial pressure on the patients in the private practice. I'm talking about private practice, and in the hospital, in Cairo University Hospital, we also are doing only the very emergency cases. Otherwise, we try to minimize intervention.
Okay. Can I have a comment, please? Of course, it was a lovely presentation as usual, Professor Sobhi. Professor Hussam, I'm humbled between two of the biggest cardiologists that I know. Thank you so much for having me with you. My question is about what would you think is the best way to triage? We don't have the possibility of a COVID lab and a non-COVID lab. Most of our hospitals either have single labs or the labs are collectively together. So if there's an infection in one lab, it will probably spread to other labs. So what would you recommend if a STEMI patient coming to our hospital, coming to our centers, or not a suspected COVID, what would you do as investigations before admitting this patient, sir?
Thank you, Dr. Ahmed, for this questions, really practical questions. I'll tell you the truth. We are doing in the university and in the private. In the university, we can do only CBC through high sensitivity component and D-dimer test, and then go if this is the STEMI, we do focus echo, and then send the patient يعني زي دعامة الحياة اللي هي ستنت سيف لايف عندنا في الكلية، لأنه اوريدي مجانا خلاص it's ستنت سيف لايف do this. Then after that, if you are suspecting this patient is COVID, then we do a CT scan to the next day. But the next day we can do this. If the patient is already, if the suspicious, we isolate in a part of our department in the ICU and the CCU, and then it's COVID. So we're telling the family this patient is COVID, and then we continue 2-3 days and send him to isolation, home isolation. Regarding the private hospitals, also we don't do CT. We do CT only, even if the patient has congestion. we just give a diuretics and then go to the patient directly to the cath lab. Otherwise, thrombolytics, we will not do thrombolytic here and that. And then we do a CT, we do a primary PCI. We do only the culprit. And even in the patients with the suspected and giving a negative COVID, we don't do except the COVID. We delayed up to 1 month, 28 days according to the complete trial, as you know. But before, we do all this in the hospitals. So what changed in our practice that we do only the culprit, and we don't do the index hospitalization visits. We don't delay the patient in the hospitals, whatever suspected COVID or COVID patients. But regarding the CT, I do the CT after doing the procedure. And they're completely different from non-ST. If you have non-ST, we stabilize the patient medically, and you have time to do CT. And also, if a non-ST, the high risk, we do our preparation for the patients, do the whatever we can do, and also we sometimes these high risk patients, we don't prolong the procedures. Otherwise, we go into complication. We can do the most we are suspecting to be the critical lesions, but the selective angioplasty for this kind of patient, for non-ST. So we are changing our policy, but we have to do an emergency. But regarding thrombolytics, as I said to you, Sky changed their idea, started, but in Italy and the United States, they have a lot of complication coming to them. And the cause of this was due to complication. Didn't see before myocardial rupture, didn't see before acute mitral regurg, don't do VSD, except in the era of Fabry life. That's why the death is more than to do primary PCR. That's why they changed it into the JAC, into the American College and European and the Canadian to do the prime PCR in those kind, whatever low risk or high risk state.
Thank you. Thank you.
I think we can go to Dr. Hussam Andil now, because already it's another story now. We come to the main bulk of the meetings.
We have non-Egyptian or foreign speakers in this program?
No.
It's a great pleasure for me to be in this program with Professor Sobhi and Professor Ahmed Shawi. I am Hussam Andil, Professor of Cardiology at Cairo University. I will be talking today on PCSK9 in post-myocardial infarction patient. I am not going to do a classic lecture, a didactic one. I would definitely opt for a lecture that I can discuss some of the topics with my colleagues who are online with us. Professor Sobhi and Professor Shawi both are very dear colleagues. Professor Sobhi is a lifetime friend, wonderful researcher and wonderful presenter. Professor Shawi is a rising star, and he's really achieving a great strides in cardiology in the recent years. So the agenda, as you see here, is burden of cardiovascular disease, unmet needs, recurrent cardiovascular events, role of avelumab in cardiovascular management, and then finally avelumab in myocardial infarction. So we'll start with burden of cardiovascular disease, and this is the world map. As you can see here, cardiovascular disease is increasing everywhere. If you look in the Middle East, you see 119% increase. South Central America, 107 increase. Very approximate numbers in Sub-Saharan Africa, 111%. But if you look in Europe and Central Asia, you find it not increasing in the same manner, 20%. And North America, you find it 45%. They definitely having a different style of life. They are working on their education and their health and blood pressure control. So the fact is that the prevalence of cardiovascular disease is increasing, and we have a large number of patients all over the world, but different prevalence. So the prevalence of coronary heart disease is expected to increase, as you can see here in this slide, and cardiovascular disease is growing health concern. Prevalence is expected to rise in a large part due to aging global population, and you can see on this slide clearly that we are having an increasing numbers of cardiovascular disease. Professor Sobhi was giving us a talk on COVID-19. We know that how COVID-19 has changed our life. But when you look, Professor Sobhi, to see that still numbers of patients with coronary disease is really overwhelming, and it's dwarfing the numbers of COVID. If we look still at the real global problem is still the cardiovascular disease. Now we look here, see that the higher LDL level are associated with greater cardiovascular morbidity and mortality, and this has been proven in the Framingham study and confirmed in the Mesterfit study. You see the lower LDL, the better outcome. The higher LDL, you see the increased mortality. Some professors I know in different institutions, especially older professors, they doubt this, but I think this is over now. Professor Sobhi, anybody has any doubt about the impact of LDL on the risk of patients with coronary disease? Do you have any comment on this?
No, I don't think so, because the guidelines are very evident in the American and European guidelines, the same since a long time. So I think
I'm not going to tell you the name of the professor.
With the change of mind from cholesterol, I mean, every patient now is saying about the cholesterol. So I'm trying to change their mind into the terminology of LDL. Everybody knows that cholesterol and triglycerides. Sometimes they don't give to you LDL, HDL. So I'm asking the patients that you have, even to write to him, the number of LDL should be achieved in very high risk or intermediate risk. So I agree with you that LDL is very important nowadays.
Great. And this is another evidence that high LDL levels increase risk of across all types of asymptomatic cardiovascular disease, incidence per 1,000 persons per year. And as you can see here clearly, the 1, 2, 3, 4, this is the quartiles, and you can see the risk increases as the LDL level increases, and this is uniform all over the world. Cardiovascular disease leads to as the global cause of death, and we have discussed this before. You have seen with Professor Sobhi how Professor Sobhi, you think COVID-19 should attract the attention more than our attention to risk factors and coronary disease? Because in our specialty, I think we are privileged that we are controlling the most serious and devastating disease. And we have to be careful about infectious disease, but still, as you can see in an NIH, you see Dr. Fauci is speaking. The NIH has different departments, and there's an NIH of infectious disease. But the most important concern of NIH is definitely cardiovascular diseases. And the recent rise of COVID-19 has changed the picture a little bit, but still the most important cause of this, as you see here, is premature death because of cardiovascular disease. As you can see here, it is 37%, cancer 27%, and other non-communicable diseases 27%. When you come to infectious diseases, you'll find it's still very small. Diabetes here 4%, respiratory diseases 3%. So we have to put things in perspective. Dr. Ahmed Shawi, do you have any comments on this slide?
I agree totally that definitely cardiovascular disease, if you look, like you professors just said, COVID-19 till now has killed 600,000 people. Cardiovascular disease, whether ischemic heart disease or stroke, kills these 600,000 in 1 month. So I agree totally. It's a bigger problem than COVID-19 right now.
Yeah, and if we can change the mindset of many people and let them understand that cardiovascular diseases are really the major killers, and COVID-19, as important as it is, but it's still a small fraction when you look at patients killed by cardiovascular.
Sorry, I can add also, Dr. Mashawi, as in my lecture, there's a slide that's called high-risk population. The cardiovascular disease, the risk of death is more than the others by the COVID itself. So the COVID increased the deaths. So the important is to control the cardiovascular in order to also decrease the number of deaths coming by the COVID itself.
Yeah, dual importance, not only as disease, but important because it's always a risk when patients are suffering from even a simple sore throat or a simple chest infection. They are even at more risk with any stressful situation, whether it is infectious or not. They are more vulnerable to have complications. This is not a new slide. Most of us know this global cardiovascular disease burden is projected to grow significantly, and We have seen here in this slide clearly that at 2015 we have 3% increase, but by the 2030 we have more than 13% increase in the cardiovascular disease. So are we having everything done in the previous years? And this is Professor Sobhi and Professor Shawki. And this is a key point in my lecture, the unmet need, because there is a clear fact that we still have patients dying from cardiovascular disease. We have great advances in blood pressure control and LDL control, in all risk factors, in stopping smoking, risk of sudden death. Everything we have done great to modify, but clearly you can see here that in patients with post-MI patients are the greater risk for recurrent cardiovascular events and death. You see this in the red line. In this blue lines and yellow lines, things are different when the patient did not have a previous cardiac event. So recurrent cardiovascular events are important and put the patient's highest risk. This has been also confirmed from the REACH registry. And to me, this is one of the very important slides in my presentation. You can see here the impact of statins on the outcomes. LDL lowering correlates with relative risk reduction in cardiovascular events, and this is a meta-analysis of 14 statins trials on more than 90,000 patients. The lower the LDL, the more reduction of events, whether this is for major coronary events or for reduction of vascular events. This is a key slide, as I'm telling you. If you want to know the core of this lecture, why would we push limits below the limits that we have seen in the previous guidelines, which is 70 milligram per deciliter. This was the magic number until very recent years, in which we felt that going beyond this number is really not needed, or we don't know what will happen. Maybe the patients will have serious consequences. Dr. Sobhi, do you agree with me that we lived in an era where this 70 was a magic number? When we reached it, we felt very good. We wanted most of our patients or all of our patients to reach it, or at least 50% reduction of the LDL. And we had no idea what will happen if LDL goes, or we didn't even have the tools to know what will happen if we go beyond 70 milligram per deciliter. You agree with me?
Yes, I think because of the 70, and then the epidemiological study found that there is a residual risk and recurrent ischemic events or peripheral events or cerebral strokes. So that's why they changed it to trying to change it to others, and they found you can say that if you make it less, are you going to decrease the events or not? Yes, so I think this is the aim of your the study. You are going to say because you need to decrease the events more than before.
Yeah, statins, in my opinion, are the most important drugs in the past 20 or 30 years. The biggest advance in our therapeutic areas is the availability of statins. And they have really made a major difference in cardiovascular outcomes. We have seen in the previous slides reduction not only in cardiac events but vascular events. But we didn't have anything beyond statins. We felt that statins are the end of the line. We were not sure if there is anything we'll be able to do that. And in many of my lectures, I say that this is the end of oral pharmacotherapy. Now we have to use biological therapy to go into another evolution. And Vuclimab really was under a big test to see whether this will be able to achieve what we want to achieve beyond the LDL reduction of the figures that you've seen before, which is the 70. So a Fourier trial was a very important trial, landmark trial, that tested whether Vuclimab given to patients with coronary disease will be able to change the clinical outcome. And I tell you, before we know the results, everybody was skeptic. We didn't know. This is an area that we never had any idea. Are the patients going to get cancer? Are patients going to get demented? Are they, when we go to LDL figures of 20, are they going to have major changes in their immunity? So many worries Dr. Ahmed Shawi, do you remember this era in which many patients or many other colleagues were skeptic and they kept saying things to say maybe it's not very useful to go to such low levels of LDL. Do you remember that, Dr. Ahmed?
Yes, the neurocognitive function was a concern, and hemorrhagic stroke were a concern. Also, the concern that LDL is required for the cell membrane structure. But I think also evolocumab's trials have shown that this is also partly a myth. Yes, but
Excellent.
Yes, of course.
So this is the outcome trial design. You can see clearly the patient's age of 40 to 85 years, a big spectrum of patients, previous infarction, stroke, or peripheral arterial disease, additional risk factor, 1 major or 2 minor, optimal background lipid therapy. Patients should be on statins. LDL has to be above 70 milligram per deciliter, or non-HDL cholesterol more than 100. And the patients were randomized 1-to-1 to either evolocumab subcutaneously at a dose of 140 milligram twice every 2 weeks, once every 2 weeks, or once every month, 420 milligram once every month, or 140 milligram once every 2 weeks. And the number of patients receiving this type of therapy was 13,750, not a small number. And the equal number of these patients were put on placebo, and the study went for 24 weeks, and then the end of the study. So what are the endpoints? Primary endpoint was composite of cardiovascular death, myocardial infarction, stroke, hospitalization for unstable angina, and coronary revascularization. I tell you, you have to choose your endpoints very carefully. It has to be composite because you go into an area where changes can be very marginal. Key secondary endpoint was composite of cardiovascular death, myocardial infarction, or stroke, and other secondary endpoints, all-cause death, cardiovascular death, myocardial infarction, strokes, and others. So the baseline risk factors, you can see here all kinds of risk factors, but myocardial infarction here, you see in evolocumab, you have more than 11,000 patients. The pointer is working here. You see more than 11,000 patients in evolocumab, and the placebo also more than 11,000 patients. So the core of the study was patients with previous myocardial infarction. This is one of the most important slides in my presentation. You can see here the drug did its magic. The drug went down with LDL to figures that we have never seen before. You see here the figures below 40 and now approaching 30. And the patients with placebo, they stayed at the levels of median of 92 milligram per deciliter, evolocumab median of 30 milligram per deciliter. This by itself is a slide that you keep looking at it for a long time. You see that the drug works, and drug works very well. And the most important thing that you are giving a monoclonal antibodies is not, it's a very safe drug. It is not going to cause any harm because you are giving a natural material. So you're not doing any harm to the patients. And this is not the time that we discuss the how does it work, but at least you see very clearly it works, and it works very well. And the primary endpoint was 15% achieved by 15% relative risk reduction in favor of reduction of composite of cardiovascular death, myocardial infarction, and stroke, and also hospitalization for unstable angina and coronary revascularization. I didn't talk about how much would it cost in the practice of Dr. Sobhi or Dr. Shawi to treat a case of STEMI or non-STEMI in their practice. It's really, we have done this before with Professor Mohsen Ibrahim. In our Egyptian practice, this is really very expensive. And the average patient, if he gets a heart attack, he can pay at least 70,000 Egyptian pounds on average to treat his heart attack. And many patients in our country cannot come up with such a huge amount in a short time. So this drug, if it can alter the outcomes and it can save lives, I think in the appropriate patient, this drug can be really a huge benefit to the patients and a huge saving of lives, and maybe as well of economical value, because as we know, in the United States and many parts of the world, they change it because of this great value. They change the price of the drug to give it to as many patients as they can. The key secondary endpoint is composed of cardiovascular disease, myocardial infarction, and stroke. And you can see here we have 20% relative risk reduction. So the primary, key, secondary, and other endpoints are summarized here in the slide. That was driven mainly by reduction in myocardial infarction, strokes, and coronary revascularizations. This is a landmark analysis of primary endpoint. For the patients with the first year, you see here still clear benefit in favor of Oreclumab, in spite of the fact it's a very short time. But beyond 1 year as well, there is 19% relative risk reduction. So the more you give this drug, the more you will get benefits. Because some patients will think of benefits only. I use it for 3 months or 6 months. It will work, but you need to give it for beyond 1 year to get this clear benefit, as you can see here, 19% relative risk reduction. And as far as adverse events, I've mentioned before that this drug is very safe. Almost no adverse events. We know that we are giving a natural medicine. It's a monoclonal antibodies, so no noticeable differences in the rate of adverse events leading to discontinuation. Dr. Sobhi or Dr. Shawi, do you have any comments until this part?
لا least number, the smallest number في ال LDL كان in this Fourier trial كان 30 ولا 25 يعني if the patient مثلا 25.
الجراف ده انا قلت من اهم الجراف في البرزنتيشنز. شايفين البوينتر ولا لا؟ كده البوينتر احنا هنا افوكلوماب ميديان مش افريج، هنا ميديان 30 وهنا ميديان 92. انما احنا شايفين الكيرف اولموست ستريت وعند ال 30 يعني. انما في طبعا حاجات نزلت 20 و10 وفي ناس اولموست زيرو.
There is a subset of patients زي ما الدكتور حسام بيه قال كان part of the safety outcomes اللي اتعملت للابينج هاوس. There was patients on LDL to 10. فزي ما الدكتور زي ما قال.
بس you don't stop, you continue.
No. Oh no, they didn't.
Okay, بس very important point يعني.
هو هنا في كذا حاجه. اول حاجه ان الدواء بيشتغل. The drug works and works very strongly, very well. We've not seen in our practice lipid lowering agents that can go to this level. And we're not here to discuss are there any patients in whom this drug will not work. Yes, there are some patients who are very rare familial patients with familial hypercholesterolemia, the monozygote type, in which maybe these patients will not respond in the same way. But if the patients have receptors, they will respond and they will get to these great levels. And I'm sure now we have patients in whom this drug has achieved marvelous results, and I'm not also going to talk about this now. So I think we can continue on the final part of the lecture, which will focus on patients with myocardial infarction, clinical benefits of Oreclumab in patients with a history of myocardial infarction, and analysis from the Fourier. And as you've seen before, most patients in the Fourier are coming from patients with previous myocardial infarction, because these patients are having the highest risk. And you know, this has been published in the New England Journal of Medicine, November 13, 2017. So the background and objectives are clear. Patients at higher cardiovascular risk may derive greater benefit from the PCSK9 inhibition. Within the broad range of subgroups of patients with prior myocardial infarction in Fourier, we investigated if readily ascertainable clinical features of coronary disease history, identified patients at higher cardiovascular risk and who derived greater benefit from PCSK9 inhibition. I'm not going to spend a lot of time on discussing the design, but as clearly as you can see here, the benefits from mainly was seen in patients of overall myocardial infarction patients in favor of the Oreclumab were highly statistically significant with relative risk reduction of 18%. And these are the features of patients with myocardial infarction. Of the 22,000 patients which are 81% of the overall population of myocardial infarction. These patients had high-risk features, and this is how many hypertensive patients, diabetic patients, smokers, and so on. LDL here, you can see it clearly in the slides. And patients with primary myocardial infarctions, multi-vessel patients, these patients, you can see all here that the male sex was the dominant sex. Hypertension was present in a very high prevalence, reaching 82% of patients with multi-vessel disease. Diabetes here reaches 1/3 of the patients in average having diabetes. Most smokers were around of 25 to 26%, and a quarter of patients smoking. Most of the patients were on high-intensity statins, and you see the figures of the LDL. Risk of cardiovascular death, myocardial infarction, or stroke. With each risk factor, you can see here that there is a reduction in benefit of the Avuculumab patients, whether you have years from qualifying myocardial infarction, prior myocardial infarctions, or multi-vessel disease. You will get a great benefit when you use Avuculumab in this study. And then this is, I think we have seen this before. If the myocardial infarction was less than 2 years before, you get clear more benefit than if the myocardial infarction was more than 2 years before. So you have to be careful and use this drug as early as possible in patients post-infarction, even the very early phase of myocardial infarction, if the patient is qualifying for the benefit. And you see here the benefit also in patients with multi-vessel disease is greater. Many times we see patients with multi-vessel disease in whom we cannot use intervention, you cannot use surgery, and these patients definitely will be qualifying for PCSK9, especially if the ventricular function is not very well, and if the general condition is also not very well. PCSK9 can definitely be a great service for these patients. This is adding on this same thing. So in summary, patients can get benefit who are closer to their most recent myocardial infarction with multiple prior myocardial infarction or multi-vessel disease, who are at 35 to 90% increased risk of major vascular events. These patients experience substantial relative risk reductions from 20 to 30 to 21% to 30%, and absolute risk reduction that reaches 3.4% over 3 years, with intensive LDL lowering with the PCSK9 Avuculumab. These readily ascertainable clinical features offer one approach to tailoring therapy. The summary is very clear. I'm not going to take much more time because this is touching on the same thing, also showing the clear benefit of the Avuculumab in patients with recent myocardial infarction or remote infarction. That benefit is more with recent infarction. So in summary, patients with recent myocardial infarction were at higher risk of major adverse cardiovascular events compared to those with a remote myocardial infarction. In recent myocardial infarction patients, Avuculumab reduced the risk of the primary endpoint by 19%, and number needed to treat of 27 over 3 years. This is really not a very large number. In conclusion, our findings corroborate that with the American College of Cardiology, American Association guidelines, recommendations to extensively lower LDL blood cholesterol after a recent myocardial infarction. Thank you very much.
Thank you, دكتور حسام. دكتور حسام يعني بس عايزين انالايز شويه القصه. هو regarding البيشنت بروفايل في اللاست ترايل غير الفورير. طبعا الفورير كان each group كان في 11,000 out of 13، يعني برضه big number of ischemic heart disease يعني من الاول.
الفورير من البوبوليشن بتاع الفورير كانوا بريجس.
اوكي. regarding this اللي هو حضرتك احنا الجايد لاينز till now. اوكي. الجايد لاينز بيوتي انا حضرتك سامعني؟
سامع.
يعني الجايد لاينز في او ريكومنديشن ECH هي او اليوروبيان ان انت PCS9 inhibition was البيشنت اللي هو not responding medical treatment reaching the target، اللي هم البيشنت اللي عندهم statin intolerance والفاميليال هايبرليبيديميا. هنا البيشنت of acute chronic syndrome ده indication ان انت you give it in the patient taking statins, in spite of taking statins عندهم history of ischemic heart disease, so you have a second attack, so you need to have PCS9 in the hospital. Do you mean this? ولا after myocardial infarction, or what kind of patient profile في الاكيوت chronic syndrome?
Mainly after the best scenario after myocardial infarction. ده هو ال highest risk patients ودول اللي بيبقوا at risk of recurrent myocardial infarction.
لا يعني هو the first اول حاجه in first time when he's live.
يعني خليني اقولها لحضرتك. If a patient gets infarction, whether this ST or non-ST, and you take him to the cath lab and you fix his coronaries, whether you put 1 stent or 2 stents, these patients are really, if their LDL is not at the levels اللي هي ال 50s اللي احنا we accept now for guidelines for very high risk patients, and the LDL level above 70, this patient definitely will benefit from Aducanumab.
So you're not wait for combination therapy. You will not wait.
No, I give all possible combinations, and if after failure of combination.
After failure the same. Okay.
Of course.
السؤال الثاني حضرتك قلت ايه الفرق بين عشان الناس تفهم بس الفرق بين الابسوليوت وريلاتيف ريسك ريدكشن؟
ممكن نوري السلايد ده فيري نايس.
حضرتك قلت السلايد اللي قبليه، ممكن سلايد بيفور، وان سلايد بيفور.
هنا السلايد
لا مش ده.
وده في ريلاتيف ريسك ريدكشن 21 في دي سبيشالز.
ايوه حضرتك قلت
21 to 30%. لكن لو حسبنا الابسوليوت ريسك، if we measure the absolute risk وده very commonly بيبقى 1% to 0.5%, you see absolute risk huge 2.6 and up to 3.4% absolute risk over 3 years. It's really very strong in favor of this intensive LDL drug lowering.
حاجه ثانيه في برضه في البيشنت بروفايل، انت في الاول فورير بتقول ان كان فيها نون اتش دي ال اقل من 100 صح؟ ممكن نرجع للبيشنت بروفايل بتاع الفورير في اول سلايد، فيرست سلايد يور فيرست سلايد. انا قلت ال دي ال هو نوت ليس ذان 70، وقلت ان كمان النون اتش دي ال. فانا اي ونت نو هل في اي داتا على النون اتش دي ال في البيشنتس اللي واخدين بي سي اس 9 ولا اكتر من 100؟
ال دي ال 70 اور نون اتش دي ال اكتر من
100. مفيش اي حاجه بقى في الستاديز بتقول ان احنا ما بنستخدمش النون اتش دي ال. انا عايز بس يعني تو جيت بنفيت اوف بي سي اس 9. خلاص احنا عرفنا ال دي ال يوصل ل 50 او 55 واقل، ولو سكندري ايفنت تعمل 40 لو جاله 2 اتاكس. النون اتش دي ال بقى مفيش داتا عليه في البي سي اس 9. انا مش شايف في حاجه. ايه رايك يا احمد شوقي؟
I did not see it as an endpoint in all the studies, but maybe there are sub-analyses. I'm not sure.
Okay. age خلاص 40 واللي هم الايدج هنا بتاعهم 40 يعني لو 39 35 لا اذا كان فاميليا هايبرليبيديميا صح كده بالفورير.
ستارتنج 40 عشان ده كلينيكال ترايل على الكلينيكال اوتكمز، واخدين عدد ضخم جدا من العيانين وصلوا 27000 بيشنت. فهنا بتستخدمه في الريال براكتس في العيانين اللي احنا بنشتغل بيهم عادي، بس درايفنج بنفيتس زي ما انت بتقول مثلا في الفور اس ايام ما ابتدوا يشتغلوا على السيمباستاتين كان الهايست بوسيبل واخدين برضه بوست انفاركشن بيشنت عشان نشوف في بنفيت ولا لا. I think انه at least at this level، واحنا دلوقتي عندنا جروبس اللي هم intolerant to statins، الناس اللي هم we cannot give statins فdefinitely they benefit. العيانين اللي عملوا كابج مثلا مرتين ثلاثه قبل كده وخلاص they don't have any solutions. I think these patients, I have many of these patients really achieving very good results. Not very many, but I have some patients in whom the benefits are clear.
ممكن تورينا السلايد بتاع 1 year ومور ذان 1 year تاني يا حسام؟ ده مهم قوي انت بينته عشان برضو الناس تركز في كونسنتريت. يعني less than 1 year انت بتقول كنت كونتينيو مور عشان مش just 1 year.
هنا البرايمري اند بوينت حصلت في يعني في ناس كتير قوي تعمل ستاديز وتلاقي ال 1 year ما فيش بنفيت.
ايوه
هنا حتى في الفيرست يير 12% بنفيت، برغم انه في عيان يقول لك هناخده 3 4 اشهر يا دكتور. طب you need to take it for a good time.
ده مور ده ريت ريسيرشن مور يعني 7% مور.
The more you take it the more you get benefit. More money will be paying off.
طب في difference in diabetic or non diabetic ولا ما فيش حاجه؟
هو الجروبس كانت mainly حوالي 30% of them diabetics. لكن انا didn't see sub analysis with diabetics. I think when you go down with the LDL to these levels the differences دي بتختفي.
طيب هم عندهم ستادي تانية على الايبس.
I think كان فيها ريجريشن.
جلاكوف ترايل برضه دي حاجه مهمه ان هم عندهم كلينيكال وعندهم نيورولوجيكال سايكولوجيكال وعندهم الايبس. فاعتقد ان في 3 ترايلز فيري امبورتنت، ويمكن دكتور احمد شوقي كمان هيقول لنا الفورث ترايل. فده اعتقد ان انت دلوقتي يو هاف ان يور بوكيت دراج. هو طبعا الاكسبنسز بتاعته هي دي المشكله فيه، لكن I don't think ان انت بعد لو 19%
هتفضل prices might go down, the United States will down. انما احنا at least we discuss the science here. الجزء بتاع البرايس ده at least you know you have benefit from the drug, clear benefit in some group of patients in whom they don't have any other solution.
ومفيش سايد افكتس خالص.
لا دي حاجه مهمه جدا، مفيش سايد افكتس خالص.
اوكي ثانك يو دكتور حسام. اوكي ثانك يو دكتور حسام. ناو ممكن نطلع اوت بعدين نيجي للدكتور احمد شوقي.
اوكي
دكتور حسام حضرتك can you stop sharing please?
Sure.
Thank you.
لا حلوه حكايه ان احنا ندسكاس توجذر دي، بتخلي الناس مصحصحه.
طبعا خلينا نرجع السلايدز ونشوفها بتاعنا كده. حفظتهم السلايدز.
احنا التايم ماشي كويس مش كده؟
ما احنا خلاص. هو دلوقتي احمد بيه شوقي بحيث نقفل على 10:30 يعني.
لا على طول.
9:30.
Thank you all for such a lovely day. I'm very glad to be with two of my professors, Professor Mohammed Sobhi, Professor Sam Andil, and I have to say that they were a major part in my promotion as a professor. So I really have to thank them, and always lovely to be with my professors. Today, you are going to help me out in this patient. I'm talking about you as attendees. This is a guideline-directed management case presentation. And I want us to take a look on how we are managing our patients and how we can do it even better or less better. So this is a 62-year-old hypertensive gentleman. He's hypertensive. He's coming to the ER with persistent chest pain of 2 hours duration. You can see at the ECG, there are precordial T-wave inversions. Also in lead 3 and AVF, there are Q waves and T-wave inversions. So this patient has to be admitted or have a troponin in the minimum. We did that. Examination showed blood pressure was above normal. Of course, with pain, this can occur. There was an apical fourth heart sound. Troponin was positive. And like Professor Sobhi said, we take a quick echo and then we look at segmental wall motion abnormality. It looks like the LAD territory, which is the septum and the anterior wall. So if this is in a COVID pandemic, this is a non-ST, we still have a little bit of time to really check the patient's COVID status. But if we're in a STEMI condition, of course, I agree with Professor Sobhi, we have to go quickly because every minute is muscle dying from the patient. And we know as coronary artery atherosclerosis and cerebral artery atherosclerosis is mainly due to instability and rupture of atherosclerotic plaques. And the cause of death, even as we're talking in this COVID pandemic, there is no numbers which are close to the numbers that are caused by ischemic heart disease death, whether the acute, whether the chronic. So ischemic heart disease followed by stroke, which are both atherosclerosis, both are the number 1 and 2 leading causes of death. And COVID pandemic, as it is really saddening and difficult, it is nowhere near the amount of death we see from these 2 diseases. And one of the most important, if not the most important for a risk factor for myocardial infarction, as seen here, is cholesterol. Cholesterol being it mainly by the LDL being the most important parameter that increases the problem of myocardial infarction. So my question, going up to questions to those attending with us. In addition to antiplatelets, of course, this patient was given ticagrelor, aspirin. Would you give statins from the start, or you just wait for the statin? Answer A, if you say no, I'll wait for the lipid profile, then I'll stratify my patient's risk. B, yes, immediately, regardless of the lipid levels in this patient, I will give him a statin therapy. So
Please,
waiting for you.
Can you vote? Can you vote?
Yes. Because this is interesting. I know risk stratification is extremely important, and we should risk stratify our patients. And I want to know, what would you do in an acute coronary syndrome? I know the lab results will come out maybe in a couple of hours the next day. Is there any data that I need to stratify my patient in acute coronary syndromes? Okay. This is quite interesting, actually, because this was years and years and years ago about the discussion on when to initiate medical therapy, including antiplatelets, including statins, including a lot of medications. This was years and years ago, when to initiate them in chronic coronary syndromes and acute coronary syndromes. What we should do, what do we do to benefit our patients? This is quite important. So we're waiting for your votes, and hopefully we're going to get them very soon. Are we getting the tally right now? Okay, I see that we have an 83% are saying yes immediately, regardless of the lipid levels, and only 16% are saying no. So excellent, excellent. In acute coronary syndrome, we don't risk stratify our patients. We risk stratify all our patients, yes, except if they are having any evidence of cardiovascular disease, if they are diabetic, if they are chronic kidney disease, if they are familial hypercholesterolemic, or the LDL levels are above 190. Otherwise, we have to risk stratify our patients. So this patient has an acute coronary syndrome, which is a cardiovascular disease and has to have its own risk stratification. So using this chart is extremely important in the other patients. And as we know, Egypt is a very high-risk country, even more. That's the new guidelines in 2019 showing that Egypt is even more riskier than we thought it was. And we discussed this, that acute coronary syndrome is rupture of a plaque, but watch out that there might be more than one or two ruptures of two different plaques, even without the culprit vessel. And here, seen regardless of the lipid levels, statins and early revascularization have improved outcomes in acute coronary syndromes. Those continuing on lipid-lowering agents have a better survival. Those discontinuing have a worse survival. So this patient is a very high-risk patient, documented atherosclerotic cardiovascular disease. And as you look at my marker, the first thing that comes here is acute coronary syndromes, followed by stable angina or the new term chronic coronary syndrome, previous revascularization, or anything in the cerebral circulation or the peripheral vascular disease. So this is really important to take into consideration. This patient, regardless of his risk, is an acute coronary syndrome, is a very high-risk patient. And these are the other risk categories that we should take a look. So why do we give statins immediately, as most of us said? Is it because they lower LDL? We've seen data with so many medications that lower LDL. Is it for other beneficial effects, what we call the pleiotropic effects, or for C, both A and B? Please vote. I would like your interaction. And of course, Professor Sobhi, Professor Hussam, I would like your comments as we go on, please.
I think after the voting.
Okay.
I think most people will get this correct.
Let's hope so. This is good. If it's something they know, this is more data to support this, and it's important to revise what we know.
Can you explain explain to them what's the meaning of pleiotropic effect?
Other beneficial effects for the statins on a plaque, on coronary vessels, other than the LDL lowering capability, which are the main thing that statins do. Professor Hussam, you said that 100% said A and B. Okay, we have professionals. So this goes very importantly. Professor Sobhi, you were saying you would like to comment after the vote?
I think 100% finished the comments.
Yeah, 100%.
Yeah,
100%.
I'd like to tell you, more than 260 audience. This is really remarkable.
Perfect.
Really congratulations.
Because they're coming to Professor Sobhi and Professor Hussam. I'm just lower than that. Thank you.
Excellent job. You're doing very
what we have data on statin therapy is if you give it in the first day, not the second, the first day, the mortality benefit is very high. Even the first day, and LDL doesn't go down on the first day. So there is some sort of indirect evidence. Yes, statins do have a pleiotropic effect. They are LDL reducing medications, thus reducing the LDL deposition in the vessels. But they do have this other effect, which has a lot of things. They decrease platelet activation, coagulation, inhibit inflammation through macrophages and endothelin and AT1 receptors. So they have a lot of things that they do. And what happens to that? An unstable plaque, as you see on the left, with statins becomes more stable. So statins are extremely important, and their usage is very important. And thus the guidelines in non-ST elevation MI and ST elevation MI say that high-dose statins, not any statin, high intensity or high dose statins are very early used as a class 1A indication in all acute coronary syndromes. So our patient was given 80 milligrams atorvastatin. We know the data with atorvastatin is huge from the Miracle study with acute coronary syndromes. But when you are going to follow up the patient's lipid profile again, would you like to follow it up after 1 to 2 weeks? After 2 to 4 weeks, after 4 to 6 weeks, or after 6 to 8 weeks? This is very important too, because one of the most important parameters that we see with poor outcomes in patients, whether it's hypertension or whether it's dyslipidemia or diabetes, is the poor follow-up. So let's see what you know about the follow-up in lipid profiles updates from the European guidelines. Of course, if you have any other comments, any other questions, please write them out. And this is really important to discuss this also. And here I would like to thank ICOM really for a great job. They're, tabulating the results, doing everything. Rihan Boulis, you're doing a great job. Thank you, guys. So let's go with the answers, please. Okay, and again, 77% go for class C. We've seen a lot of very good answering. Excellent, excellent. We used to follow up lipids. Professor Sobhi, Professor Hussam, I think you would agree, was 3 months, after 3 months, after 2 to 3 months. And now actually the guidelines after using the high-dose statins, which are either atorvastatin 40 or 80 or rosuvastatin 20 and 40, actually say we have to look after 4 to 6 weeks. They are becoming more and more aggressive and more quick in following up patients so that the patients can have a better outcome. Like Professor Hussam and Professor Sobhi were talking, we want to lower the LDL as soon as possible because this reduces infarctions, this reduces mortality. So again, very well done. So it's high intensity statin, 4 to 6 weeks. If you do not reach that, you go for ezetimibe. This is the LDL lowering guidelines, and this is very important. I know you probably know this, but quickly we'll take a quick vote. What is the LDL target in our patient? Professor Sobhi said it quite a number of times today. So did Professor Hussam. Is it below 40, below 55, below 70, or below 100? I remember Professor Hussam, Professor Sobhi, I'm not as experienced as you guys, but I remember when the LDL goal was 150, 160, something like that when I was a resident. Was it higher even there?
Yes, but we stayed a long time to less than 100, and then suddenly come to 70, but 70 doesn't stay long like 100, because I think because of the Fourier and Odyssey trials, because the Fourier trial per se, which make it less than 70. Regarding the 40, this is another story. I'm going to explain. So you have to know what's 100. اولا الامبورتنس ان انت بتستخدم الهاي انتنسيتي that you concentrate in your token وان هي الهاي انتنسيتي اللي هو ال 80 ملي جرام اتورباستاتين او 20 to 40 ملي جرام روزوفاستاتين. ده importance. The second question regarding the when to follow up your patient is for 6 weeks. The third, التارجت بقى التارجت عشان in order to get the target you have to look the patient very high risk ولا high risk. But the very high risk طب هو reaching كام nowadays according guidelines وبعدين ده first event ولا second event برضه ده الكويشن الثاني. فانت بقى
okay we have
حفظهم بقى حفظهم ارقامنا
بالظبط يا بيه. We have 61% going for 55 and 30% going below 70 and 7% going below 40 actually. I'll say B and C are correct. It depends on the guidelines you are following. Of course, the European guidelines advocate a lower level of 55, and the American guidelines still stick with the 70 because they don't have the follow-up data, the newer data like the European guidelines. So European guidelines go to an LDL below 55, the American go below 70. So both, it depends on the guidelines you're advocating. Please, Professor Hussam, you were saying?
هي انه you don't have the tools اللي توصلك لل below 70 الا لو كان عندك combination. يعني الهاي انتنسيتي ستاتين طبعا are effective، لكن البروفد هي اللي وصلت للارقام دي بالكومباينيشن. انما in general في الستاتين ترايلز below 70 ده is a achievable number. انما الارقام اللي هي تقرب بقى من ال 50s you have to use high intensity statins with the combination ezetimibe. اللي هو الرقم بقى الارقام اللي هي 40 دي لازم نستخدم بقى ساعتها اللي هو البي سي اس كاناينز. هي دي اللي وصلتنا. زي احنا زي ما يكون واحد بيسافر مثلا بالبسكليته مشوار جوه القريه، بيركب العربيه عشان انما محتاج يركب الطياره عشان يطلع من البلد. احنا you have to have the tools اللي توصلك للارقام اللي هي فيها، لان احنا اتفقنا في السلايدز اللي قبل كده ان the lower LDL the more benefit that you'll get، وان احنا شايفين انه مفيش مرحله يبقى فيها dangerous level of LDL. فاللي حطينا في الحته دي دلوقتي هم البي سي اس كي نايز، وانه I think you are running very nice discussion توري الهيستوري وتوري البراكتس. والجايد لاينز واضحه زي ما انت وريت انه اليوروبيانز بيتكلموا على ال 50s، الامريكان ستيل عند ال 70s. I'm really enjoying the presentation.
Thank you. And actually, the American clinical endocrinology guidelines go to below 55, like the Europeans. The American College of Cardiology, American Heart Association still have the 70, but actually below 50 or 55, it is shown that this is a safe way to achieve a protective LDL level. And this is why the recommended goals for LDL lowering therapy has changed from 2016 to 2019 in the very high risk, from 70 to 55 instead of or an extra 50% reduction and a 50% reduction. Just a quick explanation, what does this mean? This means if you have a patient, according to 2019, who has a starting LDL at 60 and he is at very high risk, you are going to lower it below 55, and 50% reduction, you have to go below 30. Of course, this I learned from Professor Sobhi. The way he told us this part was very nicely done. If you have a patient who has an LDL, who has an LDL of 120 to start off, and he's very high risk, you lower it by 50% to 60. That's not enough. You have to also go to below 55. So it's 55 and a 50% reduction, even if you're going to go to 27.5. This is according to the European 2019 very high risk guidelines. And this is a quick summary: 55 in very high risk, 70 in high risk, moderate risk is 100, and 116 in the low risk. But I'll tell you what the problem happened to this patient. This patient was given ezetimibe, atorvastatin 80, and his LDL was 76. And this is a really big dilemma. What would you do? Nothing, and this is acceptable. Add a fibrate, add polyunsaturated fatty acids, add a PCSK9 inhibitor. And I would like, please, when you guys are voting, please tell me what you see in your clinical practice, not just what you wish for. Because I know if it's today, we're going to go, let's do the drugs that we need, let's do what we want. Actually, we have to know that we do have some limitations in our practice all over the world. And we'll do a quicker vote. So Riham, if we can get the results a little bit sooner, we don't want to run out of time. I don't want to bore the audience and my dear professors.
النقطة اللي قلناها regarding الاتورفاستاتين ان هي should be 80 يعني it's not 40 it is 80 ملغ والروزوفاستاتين بقى هو from 20 to 40 يعني احنا we don't have 40 بس we have 20 بس دي very important لان انا I notice ان في a lot speaking about atorvastatin 40 ملغ for the patient. I don't think so. الرقم 80 ده usually disastrous to most of the patient. عشان تقول 80 يقول لك انا عايز رقم اقل. ما هو 80 ملغ atorvastatin equal 20 to 40 rosuvastatin. دي very important. إذا ما عندناش combination of atorvastatin 80 with epamide. No. We don't have. فاحنا هنقاد epamide solo يبقى 2 tablets يعني 1 tablet this one and the other tablet. لان الكومباينيشن موجوده 40 10 مش 80 10. خلاص مهمه جدا دي.
7% said A, 7% said B, 7% said C, and I agree that there are a lot of people that will agree on the first three, and 78% said add the PCSK9. I thank them. But this is a problem. Actually, the biggest problem for dyslipidemia is not the medications. We're having good medications. The PCSK9 inhibitors are present. The monoclonal antibodies are present since 2016 with their cardiovascular outcome studies, especially evolocumab. But the biggest problem is this, the problem of no longer needing after achieving the targets or nearing the targets. This is mainly not for the patient. This is mainly us as physician inertia. Please don't be inert. Try to lower the LDL because this lowers mortality and improves patients. And we have knowing that the LDL lowering medications either increase LDL removal, like statins, ezetimibe, PCSK9 inhibitors, decrease LDL production mainly used in familial hypercholesterolemia, or inhibit cholesterol exchange like the CETP inhibitors, which are, I think, now obsolete, are not going to be used anymore as much. So the LDL goal is not achieved after ezetimibe, atorvastatin. After 4 to 6 weeks, again, a PCSK9 inhibitor is extremely important in these patients, whether in the European, as we've just seen, and in the American guidelines. And they can achieve adding a PCSK9 inhibitor for an LDL reduction of up to 85%. So this patient had another problem. His LDL was still high. He was not given anything. And 4 months later, he had another non-ST elevation. Do you think his LDL targets would change? A, there is no, or B, yes, we should go lower with the LDL. So again, Riham, let's try to make it quick because we don't want to take a lot of time. And I think Professor Sobhi alluded to this question a couple of times during Professor Hussam's discussion. So this is another thing. Not a lot of data, but we'll see what the guidelines address in this recurrence of events. And I see also a lot of people are really going on the chat, and thank you so much, everybody. Really, you're doing a great job. Thank you, Reham, also. So actually, a lot of people are going with 100% are going with the B, and actually, some people on the chat are going with A. But actually, look at the nomenclature here. If you have a second vascular event within 2 years, if you remember Professor Hussam's slide, those that have a recurrent event before the 2 years are up, the mortality is extremely important and it increases a lot, and PCSK9 inhibitors actually improve outcomes. And after 2 years, the changes are there, but not so big like if we see a patient having a second vascular event within 2 years. So the European guidelines, and this is the first time this figure has been written, you can go below 40 if you have a second vascular event within 2 years. So our patient is in the hospital right now with an LDL of 74 on atorvastatin 80 and 10 milligrams of ezetimibe. Can we add the PCSK9 in hospital? A quick no or yes, please answer quickly. And this is, I think, the last question. And this is really important to see what we're thinking of managing our patients. Of course, yes, we can. I know yes, we can is a possibility, but do we have data for this? This is the important part, because we just don't want to say, yes, we can do anything for anybody. No, we have to have evidence supported, and supporting in the guidelines, this is really important. And we have a landslide again. Yes, 100%. Okay. This is actually, according to the guidelines, the ESC guidelines, those not achieving LDL levels in hospital on a maximum tolerated statin and ezetimibe, a PCSK9 inhibitor, even during hospitalization, can be given. And this is how the guidelines really put it in a context, that according to the Fourier, there's the closer there is another event, the better the outcomes with the PCSK9 inhibitors. And actually, it was not published. Actually, the presentation of EVOPAX was during the guidelines, and the guidelines were published just a little bit after, before the EVOPAX data was presented at ESC 2019. And it showed that there is a benefit of giving PCSK9 inhibitors in acute coronary syndrome patients, and it was safe. So this is what we're going to talk about. The lower, the better. EVOPAX for 5 minutes. I'm just going to take 2 to 5 minutes of your time. And this was a simple acute coronary syndrome trial. We're talking about the index event occurring, and we are taking patients with an acute coronary syndrome, and we want to take a look at the LDL level lowering if giving a PCSK9 from the start within the first to third day of hospitalization. The safety and tolerability, this is safety and tolerability data. And there were some exploratory endpoints like the high sensitivity CRP, platelet reactivity, and post-MI myocardial injury. But they were all acute coronary syndrome patients, those on high intensity statins and not reaching the goal, on low to moderate intensity statins, but their goal was 2.3 millimoles. If you want to multiply that, multiply by 39, or those with 3.2 millimoles on no statins, multiply that again by 3.39. And thus, the possibility that statins would lower the LDL to the target was quite remote. And they were divided into either giving atorvastatin 40. I know 40, Professor Sobhi was talking about 80, but 40 is data from IDEAL, and it could be given, but 80 is the preferred. But the problem with 80 is mainly the side effects. And or evolocumab in addition, of course, in addition to atorvastatin. Please, statins are really important. And looking at 4 to 8 weeks, what are the fasting lipids and what are the data seen? So you can see that 50% were diabetic, 51% were hypertensive, and actually some of the patients had a previous myocardial infarction, PCI or CABG, so they had a second event. Most of them were non-ST acute coronary syndromes, but there were ST elevation, and more than 80% actually underwent PCI, with 7% bypass and even medical therapy in 9%. There were not huge amount of patients because this is a safety outcome study. We don't require a lot of patients. Just shy of 80% were not on statins, but 10% were actually on high intensity statins. And this shows you that high-intensity statins, even on ezetimibe, you might get a second vascular event. 11% were on low or moderate intensity statins. Again, these are extremely important, that statins are very important, but again, they do not stop ultimately any acute coronary event. They improve outcomes, they lower the myocardial infarction rates, but on themselves might still have an unmet need. Again, as seen with Professor Hussam, there was an incredible reduction, very quick reduction within the first month, and second month, there was a significant 41% reduction of LDL in comparison with a high-intensity statin. This was not comparing to placebo. This was high-intensity. This was standard of care. So the LDL reduction was significant, but this is what is really important. If you look at the guidelines that in the American and the previous European, which was 70, 95% of patients, or 96% actually, on evolocumab reached the target. But with high-intensity statins, only 37.6% reached the target. So we're not reaching targets. We're having this huge unmet need, and we're not doing anything. But if you look at the updated guidelines of 55, 90% of patients on evolocumab reach the targets, with only 10% on high-intensity statins reaching. And if you add ezetimibe, I think this 10% will be 12%, 15% at most. So actually, we're not doing enough for our patients, and this is really important. So regardless, the patient was on statin or not on statin, there was a definite LDL reduction in the PCSK9 arm, which was evolocumab. This was not by any other medication. And again, reiterated, safety was paramount, and the safety outcomes was extreme. And again, all-cause death and cardiovascular death, they were the same. This was not an outcome study. This was mainly a safety study with an LDL reduction as a primary endpoint. It was perfect. But there was a trend, as you can see, for lower myocardial revascularization. But the numbers were not so big to say that this also lowers mortality. Probably if we had a follow-up for more months or years, yes, definitely, these patients definitely would have a reduction in our endpoints. There was also a non-significant reduction in high-sensitivity CRP and improvement in renal function, but again, these were non-significant. So to summarize, definitely 90%, if we're looking at the 55, we're reaching the targets with evolocumab as compared to 11% with the standard of care high-intensity statins. Not only that, this was well tolerated, very safe, without any adverse events of significance, definitely no problems with the PCSK9 inhibitors. And this was actually the first randomized trial assessing a PCSK9 inhibitor in those in acute setting. It's not like alirocumab that was given about, on average, a 1 month to 12 months after the acute coronary syndrome. This was in hospital. So this has reiterated PCSK9 in the guidelines very quickly, yes. If you look at the ESC guidelines in 2019, it's a class 1A to give PCSK9 inhibitors for those at very high risk after statins and ezetimibe in atherosclerotic cardiovascular disease, be it chronic coronary syndrome or acute coronary syndrome, familial hypercholesterolemia, peripheral vascular disease. If the patient is familial hypercholesterolemic in addition to another risk factor, this is also a class 1 level of evidence C. In acute coronary syndromes on admission, as we've seen with the EVO packs, if already on statins and ezetimibe, this is better as a class 2A level of evidence C. And statin intolerance, 3 indications: very high risk patients, those with familial hypercholesterolemia and statin intolerance, and so were the American guidelines. High level, class of evidence, level of recommendation, and class of recommendation and level of evidence in clinical atherosclerotic cardiovascular disease. Those with familial hypercholesterolemia and those with statin intolerance took a class 2B, and I'm sure they will be updated when we have when they have the updated ACC/AHA guidelines. So my take-home message is acute coronary syndromes are very serious, high morbidity and mortality. Statins, you cannot live without them, of course, unless there is statin intolerance in primary and secondary prevention. And LDL lowering is still the target. I know there was discussion on non-HDL and other targets, but actually we're not reaching our goals enough, and getting to these goals improves outcomes, morbidity and mortality and myocardial infarctions. and combination with ezetimibe and PCSK9s are extremely important. And this is class of recommendation by the ESC and ACC and AHA guidelines, especially in statin intolerant patients, especially in familial hypercholesterolemia, but most importantly in acute chronic syndromes. And these can be given in hospital, even in patients that were admitted with an acute, especially if this is a recurrent acute chronic syndrome. And here, Evopax with evolocumab has shown this result. And thank you, and sorry for the delay.
Thank you, Dr. Ahmed. الحقيقة طبعا احنا we enjoy the conclusion of the lecture is very evident. احنا speaking about secondary prevention in very high risk patients. هو ده الidea today. It's not a primary prevention. It's secondary prevention in a very high risk patient. But very high risk patient taking كلمة ما high intensity state. Will change of guidelines and enter a decrease reaching the 55 and 50% of the basal number. فده الحاجة الثانية. الحاجة الثالثة إذا كان في secondary events يبقى توصل ل 40 يعني and 50% of the basal. ده الايديا بتاعتك. الحاجة النيو مع دكتور حسام ومعاك اللي هي حكاية الأكيوت كرونيك سيندروم. دكتور حسام باين الفورير فيها 11,000 out of 13 فمعناها كلهم تقريبا اسكيميك. دكتور حسام باين ان في ستادي في الانفارشن وان هم كان 22,000 each وان هم from the first day اللي هم after. وانت بتؤيد الكيسز ديت بانذر ستادي with very evident ان انت you have to give يعني don't be afraid ان انت to give PCS9 from the day one once the patient develop acute chronic syndrome ومع taking الcombination therapy. يعني هو taking الستاتين او very intensity combination therapy you have to give. ودي 2B يعني مش ممكن تجيب لنا جدول تاني عشان انا اهم حاجه عندي عن السامري. ممكن تجيب الجدول انت كنت جبته تاني شير سكرين تاني عشان نتكلم عليه احسن. ده اصل ده جدول اليوم اللي انت قلته ده يعني جدول مع حسام ومعاك. ايوه ده بس اوكي. ده طلع ايه 1A. بص حضرتك انت جايب ايه 1A وكل قوله تاني. بص والفاميليال 1C الستاتين الاي سي اس في الادميشن if already on statin and not reaching target 2AC. تاني في الامريكان برضو 2BC. برضو لازم اشرح للناس بقى حكايه 2BC و 2AC دي عشان دي مش 1A بس 2AC و 2BC.
اوكي. A معناها multiple controlled randomized studies or a meta-analysis. B is just one randomized controlled study. C is studies or consensus of experts. This is what. And C is given mainly because the evidence was given in ACS was really through Evopax, and maybe it will be upgraded because Evopax was not actually included its results inside the ESC 2019 guidelines. There was mention that it was ongoing within the guidelines. Class 1, yani you must do it. Class 3, you don't do it. Class 2, you should do it if it's A. B, it's preferred. It's not contraindicated. It's better to use. Again, this is just how to summarize the classes of recommendation and the level of evidence.
أنت already in the second event of these patients هو in spite of take combination هو ما فيش other option يعني yes. عشان VC ده أنا مش فاهم إنها إزاي ما فيش other option. طب what's going other option إنك تدي anti inflammatory اللي هو في residual risk ده مش atherosclerosis إن هو من inflammation. أنت عارف إن في 2 studies على الانفلاميشن maybe this kind زي كولشيسين مثلا او الكانيكامب ده انك تديه بس مش عندنا لكن كولشيسين. فانا على فكره بعمل كده دلوقتي بعمل PCS9 بلس كولشيسين لان I don't know the residual is coming from where. هل هي اثيروسكلوز ولا انفلاميشن؟ ما اعرفش رايك ايه يا حسام في موضوع الانفلاميشن
والاثيروسكلوز. I think it's a good drug بس احنا الريدكشن اللي بيحصل بالPCSK9 is humongous. لو انت بتنزل بالريسك ال LDL الارقام الواطيه دي خلاص انت الدنيا اختلفت خصوصا لما قدروا يثبتوا بالجلاجوف ان هم بيحصل ريجريشن. انت عايز ايه في العين تاني انك تبقى تعمل ريجريشن. انا لما دخلنا كليه الطب كان الاثيروسكليروز ده disease that will always kill the patient. There is always يعني progression وما فيش حاجه اسمها regression. واهم سبب للsudden death coronary disease. انما لما ظهرت الستاتنز وابتدى الامور اتغيرت، ابتدى يبقى في كونسبت بتاع ريجريشن، وحتى الريجريشن ده كان موجود بال 80 مللي جرام من الاتوربا وال 40 مللي جرام من الرزوبه. الريجريشن ده في رايي دي اهم فيتشر، واحنا طبعا كنا looking for much يعني bigger regression، بس انت بتبتدي مع عينين اصلا difficult. لو انت started بالبي سي اس كي 9 عينين عندهم ال دي ال ليفلز اعلى من كده، كنت هتشوف ريجريشن ليفل عالي جدا. انما انت بتشتغل على عينين اصلا واخدين ستاتنز واوريدي البروسيس فيهم ابتدت قبل كده، بس still you could see more regression. فطبعا دي كونسبت كلها جديده خالص، واي ثينك ان هو يعني احنا بنبص بقى اللي هو الدواء لما يبقى وانس يير هنبطل شغل كلنا بقى.
المفروض every 6 months or 1 year. لا هو طبعا احنا في الايرا بتاعه البريفنشن. طبعا احنا ما اتكلمناش على برايمري بريفنشن، يعني لو هتحبوا تقولوا على البرايمري بريفنشن حاجه يا دكتور احمد شوقي. يعني دلوقتي لو انت عندك واحد عنده ما عندوش سكندري ايفنتس، ما عندوش، مش محطوط في الكاتيجوري ده، واحد دايابيتك بيشنتس، واحد عنده 190 ال دي ال، هل في evidence انك to give PCS9 in those patients not reaching the target في بعد combination، ولا ده بقى مش available؟
لا there are data. هما 3 categories of patients. very high risk patients بالذات acute chronic syndromes، ودي معظمهم اهتموا بيها which is very important. The familial hypercholesteremia whether heterozygous or homozygous or the statin intolerant. Some high risk individuals getting PCSK9 for lowering their LDL, regardless they have atherosclerosis, there are present, but the data is not so much. Yes. And also the cost effectivity is a little bit questionable. So this is another problem which is a little bit in the primary prevention, maybe the cost effectivity.
اللي بيقوله الدكتور حسام ده اللي هيجي جديد ده على غالبا على البرايمري بريفنشن اكتر منه السكندري بريفنشن. لكن احنا قدامنا داتا من studying FOURIER Odyssey trial، ودلوقتي ما كانش عندنا evidence regarding acute chronic syndrome، لكن احنا we have evidence acute chronic syndrome, we have numbers. I think ان احنا we are on the track, the proper tracks. I'd like to
هو برضه قبل ما الدكتور صبحي يقفل، دي تخصصات زي الفاسكولار سيرجري مثلا اللي هم اللي قدر منهم يقرا ان في بروجرس وانه الانترفنشن والدومينيت they survived. اللي منهم persisted على التايب كلاسيك سيرجري I think they suffered. الدنيا تتغير حوالينا بسرعه جدا. اللي هو المصورات اللي شغال الكاميرا العاديه اللي هو ما عملش ديجيتال الكاميرات انتهت. فاحنا we have to be يعني wise and see the future، وانه الانكليزين is coming، و I know ان هو coming very fast، وانه الكونسبتس بتاعت البي سي اس كي 9 دي are very good و strong concepts. فاحنا we have to be ready for the future، وزي ما حضرتك قلت كده سواء في البرايمري او سكندري بريفنشن الدنيا هتتغير.
تمام. طبعا any questions منكم؟ هو الحقيقه على فكره عندنا لغايه دلوقتي 242 اتندي 242، وده جود نمبر فور 90 minutes. وان احنا عندنا الحقيقه والدكتور حسام كان بيقول لي نتكلم عربي وانجليزي في الاول، بس احنا اتكلمنا انجلش. لكن احنا يا جماعه لو انتم سامعيننا كمصريين او عرب، احنا بنتكلم انجلش because it is اللي هو اللانجوج نيدد، ان هو الويبينار ده spread it all over the world. It's not just local webinar. And I'd like to thank Professor حسام الحقيقه for a wonderful presentation and discussion regarding الفورير والeffect وحتى في الكوفيد، والدكتور احمد شوقي. واحنا وصلنا conclusion النهارده مع بعض احنا الثلاثه. نمره واحد الكوفيد is still there، وان احنا we have to have PPE. We have to treat the patient as if it's COVID or possible COVID. We don't change the guidelines. We have to be ready for any complication. الفورير is coming to stay، وان احنا عندنا we have to reach guidelines mainly اليوروبيان اللي هي 55 for very high risk، والسكندري ايفنت يبقى 40. لو انت هاي ريسك يبقى 100، intermediate risk between 110. ده للارقام. والفولو اب بعد 4-6 weeks ونعمل كومباينيشن. if failed 4-6 weeks PCS9. والدكتور حسام والدكتور احمد قالوا PCS9 from the beginning of acute infarction. ده الجديد النهارده ان احنا acute infarction. وانا بشكركم جميعا، وبشكر شركه امجن، وبشكر ايكون for preparations والاكريديتيشنز وفور technical support. Thank you very much. Enjoy the weekend.
Thank you. Bye-bye.
Bye-bye.